Well, ladies and gentlemen, what a pleasure to welcome you to this webinar, which is a pretty remarkable affair. You're about to be astounded that you are being joined by something in the order of 1,500 registered delegates. The numbers keep going up. We couldn't keep up. So many of you wanted to join us, and you'll see that you have come from more than 80 countries around the world. Really, the global rheumatology audience coming together. So we're very grateful to you for doing that. Thank you so much. It's also gratifying to know that so many of you have actually been sufficiently interested and provoked by our faculty as to bring more than 80 questions so far into our inbox. Now, you'll appreciate we'll not be able to answer all of them, although those that are most pressing and those that have come up most often, I'm sure we'll get round to. But be aware also that we're going to be able to potentially get some of these answers for you online at a subsequent time point. So no good ideas will be forgotten or missed. So I need to say thank you very much indeed to our sponsors. We received educational grants from AbbVie and Lilly to support this. You'll appreciate that in these very strange COVID times, this is not a promotional award. This is really an effort to allow us to convey to you what we believe are the best approaches to the management of rheumatic musculoskeletal diseases at this time. A few housekeeping remarks for you. You're all going to be on mute for the duration of the meeting, and that's so that we don't hear you eating your breakfast or your lunch or your dinner or your midnight snack, depending on what time of day it is for you listening around the world. We would, however, ask you to offer us questions using the Q&A option. You can ask them at any time during the webinar. We're only going to be answering them verbally at the end, at the closing question and answer session. But if there's some obvious questions come in, we can try and answer those for you online. And if you have any questions, any problems, technical difficulties, use the Q&A box, and our friends in the head office will sort it out for you with the wizardry that is the modern electronic capability that they have nowadays. Well, the good news is that there is accreditation, one European CME credit from UMS EACME. So after this meeting, you'll receive a certificate of attendance via email, and I hope that that's going to be useful to you as we continue to develop our own ability to look after our patients to the best of our ability. Well, it's really a pleasure to introduce you to this webinar. We're going to be thinking about the implications of COVID-19 for our patients with inflammatory rheumatic diseases. It's a very challenging time indeed for us. Many of us have had to turn our hand to internal medicine, to the management of patients really acutely unwell. And for all of us, it has been a challenge, not only to deal with that acute coronavirus problem, but also to be thinking more widely about how do I make the right decisions for my patients who have rheumatic musculoskeletal diseases. Now, in the absence of evidence, remember only a few short weeks ago, this was a disease that didn't exist. We are moving to a time when we have to make decisions on the basis of limited evidence. And so it's a real reassurance for us to have brought together a faculty of international outstanding preeminence. And I'm, for one, looking forward to learning from them all. Just to briefly introduce the faculty, I'm Iain McInnes. I'm a rheumatologist working in Glasgow in Scotland. Professor Kevin Winthrop is a world-class infection biologist. Actually, he's an honorary rheumatologist. Kevin, we think of you as one of our own. The lovely thing about Kevin is he speaks our language, even though he comes from Oregon, which is truly remarkable. It's very early in the morning for you, Kevin. You look very bright-eyed and fresh. It's great to have you with us. Looking forward to learning from you momentarily. A pleasure to welcome Chris Edwards from the University of Southampton in the United Kingdom. Chris, similarly looking very dapper, although for us it is getting towards the end of the day. And the days in the UK at the moment, because it's summer, are pretty grey and rainy, and therefore it's so very nice to have you. And yet you still look so cheerful and happy and smiling, because I don't know quite how you do it. Chris is going to take us through some of the very clinical elements, as is Professor Johannes Biljsma, my very dear friend and colleague, my partner in crime at EULAR, Hans, I think. But Hans is going to guide us through some other really important clinical elements in the management of people in this time. Hans, as you well know, is from the University of Utrecht in the Netherlands. And finally, Professor Kimme Hyrich from the University of Manchester, who is showing off her bookshelves today. Kimme, it's lovely to have you joining us. Kimme is one of the foremost epidemiologists in the world of rheumatology and is going to bring us up to date with what is the beginning, the evolution of a database and an evidence base to inform our practice. So welcome to all of our faculty. It's great to have you with us and we're looking forward to learning from you. Well, this is what we're going to learn. We're going to spend a little bit of time thinking about the nature of the virus, compare, contrast it with other viruses and indeed other viral infections. And then we're going to think a little bit about the options and the strategies that we have for looking after our patients during the pandemic, and maybe even thinking beyond in Q&A to how we're going to deal with COVID as an endemic rather than an acute insult to our consciousness. We're going to think a little bit about the options and strategies for management of people who have contracted COVID-19. We're either at risk or we already have the virus. And finally, we're going to think a little bit about the role that the COVID-19 registries, which have been formed very rapidly and unfortunately are accruing patients very quickly. I say unfortunately because, of course, each new event is a patient infected. But Kimme is going to guide us through just exactly what we can learn from those registries now and going forward. We're going to stick to our agenda reasonably tightly because we do want to reserve time for questions and answers. The times shown here are British summer time, and you can translate them into whichever time zone you're in by subtracting or adding the relevant number of hours. Obviously, I'm in Scotland, so I'm about 100 years behind, but that's an easy calculation. It's still 1635. If you want to know a little bit about this, the webinar after the event, the information we're going to give you is up to date as far as we can possibly manage. But we are updating our online website at the Citing Signaling Forum. So you'll be able to go online there and find as up-to-date information as we can subsequent to this. So if you're looking at the webinar at a later stage, that would be something that would be useful to you. So I'm going to hand over now to Kevin, who's going to guide us through a primer, an introductory course to the SARS-CoV-2. It's a novel virus and certainly has been an insult to all of us in terms of our thinking, a truly disruptive event. Kevin, I'm looking forward to hearing from you.
Great. Ian, thank you very much for the introduction. It's great to hear your voice. And everyone on the call, nice to see you. I'm sorry we're not getting together at EULAR. I miss you guys. Everyone misses everybody right now. So thanks for putting this together. It's my job to give you guys a brief overview of the SARS-CoV-2 virus, which causes COVID, in 10 or 12 minutes, and take you through a bit through the clinical presentations and the pathophysiology, and as well as highlight some of the therapies that we're starting to use against this creature, or this RNA virus, and then turn it over to you guys to talk more specifically about the rheumatology impact. So thanks for having me. Very quickly on the screen here, I think you can see this. This is my basic science slide condensed into one, and you can see on the left-hand side of the screen, the authors of this article are making the point that this is a SARS coronavirus. So SARS-CoV-1 or the original SARS coronavirus is what caused SARS a number of years ago. And this virus has a high degree of homology with that virus. And they both use the ACE2 receptor to enter host cells. And the way the coronavirus, you can see in the middle here, is set up is there's all these S proteins, these spike proteins that radiate around from the virus. This is the crown, or these spike proteins are really very antigenic. It's the way the virus grabs a cell and enters the cell. And if you look at the figuration or the actual structure of that S protein, it's really kind of a two subunit deal with an S1 and S2 subunit with a little site in between, a cleavage site in between. And the S1 subunit really is what binds the host cell, and the S2 is more involved in the fusion and the entry of the virus into the cell. The authors of this article also did some work around looking at, and it's not showing up on the bottom of the slide there, but this figure at the bottom, they actually took some mice and they were able to show that neutralizing antibodies produced in mice when exposed to the original SARS actually neutralized SARS-2. So there was some hope that there was enough homology between this, that individuals who'd been exposed to SARS before might have antibodies against the current virus. Here's just another schematic showing, here's COVID or the SARS coronavirus 2 here binds the ACE2. And then again, this ACE2 is what is involved with endocytosis and the virus into the lung cells or other cells in the body. Of note, there is a kinase, several kinases that are important here in facilitating this endocytosis, and the ADP2 kinase or AAK1 here, as is shown in the circle, is very important to that process. And note, there's a number of molecules that inhibit that kinase. Some of these are cancer drugs, and this is a drug that you know here, baricitinib. Now, while this inhibits JAK1 and 2 primarily, it also inhibits AAK1 or ADP2 kinase, which could then theoretically diminish the endocytosis of the virus. One thing I'll mention too is the concern around ACE. NSAIDs upregulate ACE receptors on cell surfaces, as do people take, as do drugs that block ACE, and ARBs and ACEs, ACE inhibitors. So the concern with all those drugs was originally that the ACE2 receptors would be upregulated on cell surfaces, and the virus would simply have more targets and to hit in terms of entry of cells. I think that hypothesis has not borne out in clinical data thus far. Okay, here, sorry, I'm having a slide advancing problem. They just keep going forward on me. See if I can get them to go back. There you go. Perfect. Thanks. So I mentioned the mouse data that showed cross-neutralization of both SARS-CoV-1 and CoV-2 by neutralizing antibodies. Apparently in humans, however, this doesn't work. It's a nice example of what we see in the mouse does not translate to the human. There's several studies now showing that people with SARS still have actually neutralizing antibodies 6, 7, 8, 9 years after infection. But that neutralizing antibody does not actually neutralize the current SARS-CoV-2. There's enough differences in that S1 and in that receptor binding region that they don't cross-neutralize. So the current epidemiology, you can see this really started back in January and February. This is WHO data, and you can see that the initial insult of the virus, of course, was in Asia, although we know now in the US, it was in the US also at this time. It was also in Europe in late January. And you can see that the epi curve here, these are the daily case counts, and we're now over 3 million plus cases worldwide. And this is spread equally through Europe and the Americas quite rapidly. And now we're starting to see it down here in other countries, including other regions of the world, including Southeast Asia, South America, and Africa. Some differences between the original SARS, that's why I call SARS-CoV-1. We really lucked out with SARS. I mean, we dodged a bullet. Almost everyone with SARS had a fever, which made fever screening viable. Only about 2/3 or maybe 3/4 of the people with COVID have a fever. So fever screening is less reliable. So we were able to screen people at airports with SARS and actually keep them off planes and keep them from traveling around the world. The other aspect about SARS is it was a lot more lethal than the current virus. So the mortality rate with the original SARS was probably more like 6-8%, whereas here we're probably more like 0.5, 0.2. I have a big range there because the range depends on where you are in the world, but it's really about the denominator which drives that range. But we're probably somewhere around a 0.5% mortality rate, which is probably 10 times less lethal than SARS. There is probably a little more aerosol spread with the original SARS, whereas the current virus, COVID, is really more droplet and maybe has some aerosol component. The distinction between aerosol and droplet is a bit of a continuum. I mean, it's not like there's just big droplets and little droplets. There's obviously droplets of all size, and they go different distances. So, but SARS, there was evidence of spread through air conditioners and ventilation systems. We don't see that with the current virus, luckily. The biggest issue here is the asymptomatic transmission. This COVID is really quite unique in that. With the old SARS, you can see here's on the graphic, 0 days from symptom onset of primary case. So this is symptom onset. You see people start virally shedding about day 1 or 2 into their condition after the symptoms start. With influenza, it's a little bit like this. You actually see some viral shedding a little bit before symptom onset, or really coincident with symptom onset. Unfortunately, with COVID, as you know, you can have viral shedding for 4 or 5 days before symptom onset. And in fact, some people never develop symptoms at all, yet they can be shedding and causing transmission. And that's really what makes this virus different. Not to mention the fact that no one had primary immunity to this virus whatsoever in the world, which is also distinct from influenza. Of course, there's lots of baseline immunity out there. So this virus is highly transmissible, hard to screen individuals before travel or before walking into any sort of setting, and you don't really know who's infected. Add to that the lack of testing in many parts of the world, including the US, and you're basically operating in the dark and you have no idea who has it and who's spreading it. So what's your answer? You close everything down for a few weeks or a few months until you have the ability to test or have the ability to treat. Next slide. Let's see if I can get that to go. This just showed some comparability between SARS, the 2 SARS viruses, in terms of their ability to survive surfaces. The viable virus can be found. You can just see, I'll just point out cardboard down here because we get all sorts of boxes from Amazon and mail carriers, and I'm sure you do too. But the virus can survive about 3 or 4 days on that cardboard, which is a couple days longer than the original SARS virus. So the current COVID is in red and the original SARS is in blue. You can see though on most surfaces though, they're fairly comparable, but this virus seems to be a bit hardier on certain surfaces, particularly cardboard. So leave that Amazon box in your garage for 4 days before you open it. Next slide, please. I can't quite get this to advance. Thank you. In terms of presentation, I said, about 3/4 of the people have fever. This is one, case series of actually individuals with rheumatic disease, PSA, PSO, RA. This was published from New York City in the New England Journal. It's a small number of people, but it is representative of what you see in the general population. About 2/3 or 3/4 of individuals have fever, cough, shortness of breath. There's not a lot of rhinorrhea. So I have friends who call me, they say they have a runny nose. I tell them they have allergies. They probably don't have this. Sore throat is present in some. A lot's been in the media about changes in taste and changes in smell. That certainly does seem to be somewhat characteristic of this and distinguishes it between influenza, for example, where that's less common. The other thing that should be said is the silent hypoxia. I think there's been lots talked about that in the press. People certainly are hypoxic, or a large proportion of them are. And if you're not an active person, you may not notice it, but if you're an active person, you certainly will notice it. Next slide. Risk factors for death and badness, really it comes down to age as a very strong risk factor. This is from a Chinese cohort that was originally published. There's a number of comorbidities that seem to be overrepresented in people hospitalized and dying with this. Although when these investigators modeled it, only age maintains its statistical significance. And more recently, actually, in the US, of course, BMI is a very strong independent risk factor for death with this. So I really think about age and BMI as probably your two strongest risk factors. And then some of the other comorbidities, I'm sure, are also increasing risk. Biomarkers for badness, high IL-6, high D-dimer, and low lymphocytes all seem to be risk factors. If you develop this in your hospital and you have those characteristics, you're at high risk for death. Next slide. And the high D-dimers plays right into this therapy. This has become pretty standard of therapy around the globe in the last several weeks. A number of patients that were died were autopsied, of course, and microcoagulation and clotting was noted throughout the lungs and elsewhere in the body. And it seems to be that a big part of the pathology of this disease is actually clotting. So this was a observational study, not a randomized control study, but clearly you can just look in group B here, the patients on mechanical ventilation, people who were given anticoagulation had a much greater survival than people who were not. So that's the blue versus the red. And you can even see that in all patients combined. So this has become standard of care that at least in my institution, people meeting certain criteria with regard to D-dimer and level of care are being anticoagulated routinely. Next slide. In terms of therapies, I have just a couple slides on antivirals, remdesivir, which is an RNA polymerase inhibitor. This is an agent that we've all been hoping is going to pan out. It has in vitro action against a number of viruses, including SARS. You can see also RSV and MERS. So MERS and SARS are the two related coronaviruses to the current COVID. And this drug in vitro appears very active against them. It also was active against MERS in a macaque model, but wasn't tested against SARS in humans. There was an open label study that was encouraging. Next slide. And in a double-blind RCT from China that was published a few weeks ago, unfortunately, really didn't show any benefit at all. You can see time to improvement here as the primary outcome measure, and there was no difference in the Kaplan-Meier curve here between remdesivir and control. Next slide. However, if you listen to Tony Fauci talk on TV, like we all do, because it's hard to listen to anyone else talking on TV with him, you know, he touted a study recently that was stopped prematurely by NIH, by the DSMB. I'm not sure they should have stopped it prematurely, but they did. But this remdesivir study actually showed some signs of, I would say, modest benefit. And you can see here that, you know, these were hospitalized patients who were hypoxic with COVID. And you can see here that 31% improved their clinical outcomes improved slightly faster and 31% versus 31% faster. Sorry, my slide was blocked by something. The mortality rate was really no different between the groups. It was slightly better in the remdesivir group. I can say being involved in a number of therapeutic trials right now against COVID, these studies are very difficult to analyze. The outcome measures aren't quite hammered out yet, and how to analyze the subgroups of individuals in these studies is very difficult. So I think this is a preliminary result. I'm not sure this is the quote unquote standard of care yet, although it has become, at least in the US. There's obviously limited doses. I think if I were sick, I'd probably want to be on it, but it's not clear to me that it's that effective yet. And we need to see more data. They haven't really released any other data from the study that I'm aware of. Next slide. Hydroxychloroquine, this was the initial slide. This was Raoul Didier's group in France. And you could see this one line here that showed the lowest viral load or the best viral clearance after taking hydroxychloroquine azithromycin. This caused quite a bit of optimism. Next slide. However, all the studies since then have been negative. This is an observational study of hydroxychloroquine in France, which I thought was quite well done, actually, looking at people on hydroxychloroquine using propensity scores and matching them to people not on hydroxychloroquine. You can see the relative risks of outcomes here were all about 1 in terms of death, transfer to the ICU, et cetera. It showed no benefit. Next slide. An open label study in China also, you can see the Kaplan-Meier curves are similar. also showed no benefit. Next slide. The Chloroquine trial, which made the news worldwide, was stopped prematurely, or at least actually the high dose chloroquine arm was stopped prematurely. I haven't seen the data from the low dose chloroquine arm yet, and you can see that the risk of death was greater in the high dose chloroquine arm. This was due to side effects, cardiotoxicity primarily of the high dose chloroquine. So this kind of put a nail in the coffin of the chloroquine. So far hydroxychloroquine has really not panned out in any of the trials. There's of course a number of RCTs still ongoing that we look forward to reporting to see an answer. Next slide. And lastly, an open label study with anakinra was just published. This was showing that people were more likely to survive on anakinra than quote unquote standard treatment, which was essentially not anakinra. Most of these people were on background hydroxychloroquine, some were on remdesivir. But again, you can see the separation in the survival curves, and the people with anakinra did better. So again, there are RCTs ongoing with anakinra. We look forward to the results. And I think my last slide, please, is just what's on the horizon. As you're aware, there's a number of IL-6 blockade trials around the world with both sarilumab and tocilizumab. The JAK inhibitors are now starting to be looked at. Baricitinib, which I mentioned, has the theoretical ability to block viral entry into a cell. That and tofacitinib are both going into trials. Abatacept, there's several trials starting. The AIDS drugs, lopinavir and ritonavir, have been negative so far in the trials. I don't think they're going forward at all. Favipiravir, which is a drug from Japan and Russia, seems to have some promise. That's also in a phase 3 trial. Losartan is the blood pressure pill that I take. I'm hoping it is doing something other than keeping my blood pressure low. But that also, again, can block that association between the virus and the ACE receptor. So there's some hope with that organ or that medicine as well. Other immune modulators, lots of people are throwing their hat in the game here. Anti-GM CSF. There's a sphingosine 2 kinase inhibitor trial that actually I'm helping do. And there's a number of other both antiviral and anti-inflammatory compounds under study. So I think there's hope out there. Next slide, I think, is just my thank you slide. Or no, plasma. This is the last slide. It turns out that individuals do produce neutralizing antibodies after infection. You can take those antibodies from an individual and give them to someone else and improve their survival. This has been shown. It was a small study, but it was shown in China. And now, as you're aware, many of the companies that you guys have worked with for many years, developing many of your medicines, are in the game of making monoclonal antibodies directed towards this virus. And most of those studies will start in June or July. I think they should work. I think they have great promise, but these will be neutralizing antibodies that are produced, manufactured, and given to individuals in various stages of their illness. So we'll just have to figure out how to use them. I think they will work, but I am very hopeful by late fall we'll have some therapies that will be money, so to speak. So with that said, I think I'll turn it over to the next presenter. Thank you very much.
That's great.
Be advancing now, and thank you.
Wonderful. Well, thanks very much indeed, Kevin. That was terrific. We're going to move rapidly on now to listen to Professor Chris Edwards out of Southampton, who is a professor of rheumatology and a really fine clinical rheumatologist. So, Chris, over to you.
Okay, thanks very much, Ian. And it's a pleasure to be speaking to you all around the world in all the different countries. I'd just like to echo Kevin's comment at the beginning. The thing that we're missing perhaps most is our colleagues and interacting normally. And I'll tell you a story that last week I dreamt 3 nights running that I was in Terminal 5 of Heathrow Airport. So I think I'm missing the traveling to meetings as well. Okay, so I'm going to try and talk about some of the nitty gritty of how we might organize our practice and the decisions that we might make. Let's see if I can get this to advance forward. Okay, that seems to be working. Okay, well, here's a slide from with a quote from a colleague in Italy, which sums up some of the feelings and some of the experiences we've had. And many of us have had to change what we do in the last few months quite profoundly. Many of us have ended up wearing surgical scrubs, being on general medical wards. Many of us have been involved with research studies. And And throughout all of this, we've been trying very hard to continue to manage rheumatology patients and to decide how to treat them with the least risk possible, both of disease activity and of infectious disease, while also considering ourselves and our colleagues as well. So this is probably the most important slide. You know, what are the goals of running a rheumatology service during COVID-19? And one of the first things we struggle with is just how we reduce the risk, how we assess the risk. And Kevin's mentioned, to begin with, we really didn't know how many people would die with this, what the case fatality rate was. And having spent some time working in Singapore 20 years ago, the hospital I worked at, Tan Tock Seng Hospital, was the SARS hospital in 2003. And the stories I heard from my colleagues there of how difficult it was to manage really certainly frightened me at the beginning. And perhaps the mortality figures now make us a little bit less worried about specifically our patients and the case fatality rates. But so first of all, it was reducing risk. Then we didn't want to get rid of all our rheumatology services. During whatever happened, we didn't want people with giant cell arteritis to be going blind because they couldn't get hold of a rheumatologist. So having ways to assess and treat urgent rheumatological problems was vital. And also the importance of maintaining disease control, not just as a concept, not just as treat to target and the things we've been taught in the past, but also because uncontrolled disease increases infectious risk. And then lastly on the slide, this is an opportunity, and this is the optimism in me perhaps, because these are opportunities as well as being difficult, are opportunities to learn, to improve what we do. And I think some of what we change, we will not change back after this crisis is finished. So what considerations might we have? So there are things around reconfiguring the rheumatology service, and much of this will already have been done, although with subsequent waves, we may have to become used to living with coronavirus for a period of time and understanding how to run our services. And some of this right at the beginning was the challenge of many of our colleagues being sent to other parts of the hospital. How do we run the core service? And then there's the bit about managing patients, how we shield, meaning really lock people up on their own, keep them as far away from other people as possible when they're very high risk, or isolate individuals who are the most immunosuppressed. And then things around therapy, which I'll come back to as well. But this idea of maintaining disease control because we don't want the disease to get out of control, but also that probably increases the risk of infection as well. So how might we reconfigure a rheumatology service? Well, there's a need to try and reduce face-to-face contact while this is going on. And I think many of us now are doing more telephone clinics and virtual clinics than we are face-to-face. But we need to be able to see those emergency patients, and those patients have to come into the hospital. So there is some organization around that with how you socially distance, the appropriate use of personal protective equipment, and then smart scheduling, by which I mean patients having longer in the clinic, bringing a patient in one at a time, getting them to arrive in their car, for example, and texting them to call them in when there's a clean route for them to come into the clinic room, and then cleaning the room afterwards. That takes time and that takes organization, but it's important to reduce the risk of exposure in hospital. Because some of the data that's coming out of some hospitals, certainly the one I work in, is some of the biggest risk to patients is when they come and attend, and particularly if they're inpatients within hospitals. So what about some general principles around managing patients? Now, this is where rheumatologists become vitally important in this. There's national guidance in many countries about who we should shield and isolate and how we should socially distance. But it really needs a rheumatologist to decide for an individual who should be shielded, who should be isolated, and how we protect them in the best way possible and weigh up those risks. I'll come back to that in a moment. And then there's some other things that certainly we've considered in our department about when we can, reducing the frequency of drug monitoring to the least often possible, given safety concerns around that. In some individuals, for example, being treated with tocilizumab and abatacept, we've changed all IV patients to subcutaneous to reduce contact with the department in the hospital. And for new starts, we've thought about shorter half-lives and oral and subcut therapies, shorter half-lives with etanercept and with JAK inhibitors, for example. And then there's some other things that Kevin's already mentioned around ACE inhibitors, probably less of a worry now, Vitamin D probably for all our patients, because if they're indoors, they're not getting sunlight and their bones are getting weaker, but also it might be improving their immune functioning as well. And don't just suddenly stop the steroids, but keep that dose as low as possible. So this slide is about the sort of ideas we have to think about when we're assessing the risk for an individual patient, and we're trying to find the correct nuance for an individual. There's that interaction between the rheumatic disease itself, the infection from the virus, and also the comorbidities that are present. So different patients with the same disease having the infection may be at different risk because they're different age profile or because of a different racial group. Some of the data, certainly from the US and the UK, is showing that some Asian and individuals of African ancestry might have a higher risk of doing badly associated with those diseases. And all that needs to be factored into decision making. Now, this is a complicated slide, but I will walk you through it, and it's available online. This is the BSR's way of trying to divide patients up into 3 groups to decide how much they should isolate from society. On the left-hand side is the concept of individuals who should shield, stay at home and have as little to do with any other individuals. And within the box below, you will see these are the people most immunosuppressed, highest dose steroids, cyclophosphamide, multiple different immunosuppressives in uncontrolled disease. And just as a personal example, the person I've seen who has been sickest of my patients is a man with bad ANCA-positive vasculitis, whose misfortune was to need cyclophosphamide for his renal disease just before the virus really took off, and spent 3 weeks on the intensive care unit. And thankfully, it is recovering slowly at the moment. And then on the far right side, there's the general population, people who are well controlled with just drugs like hydroxychloroquine and sulfasalazine, probably not a big risk. And then, of course, most of our patients end up falling into that middle group where it just needs intelligent risk management and weighing up between the rheumatologist and the patient. A little bit about drugs, and we've heard about these so far. And this is a table that's almost a cartoon, just to think about the way we might think about different classes of drugs. So which are the drugs that are likely to immunosuppress most of our patients? Does route make a difference? For example, if a risk is coming to the hospital, how do we reduce the amount of intravenous treatments that we're giving? Can we change to subcutaneous? Do we need to think about using more oral therapies in the future? And then I certainly wouldn't advocate changing. Largely, we can leave our patients on the medication they're on. But if we're starting new drugs, we might not just think about the route, but we might also be thinking about the half-life and the likelihood that the drug will be out of the system more quickly if someone was to develop a nasty COVID-19 experience. And then the trials Kevin's already mentioned on the right-hand side. I mean, one of the things we need, and I think Kimme will probably touch on this, and Hans with the information we require at the moment, is try and understand really how much our patients are at risk. I'll give you an example from our approximately 1,000 patients on advanced therapies in Southampton. And of those individuals, we've had 2 patients who have had COVID-19, one of whom, at least proven COVID-19, swab positive, one of whom's been admitted to hospital and required oxygen therapy, had other comorbidities and was in her 80s. But largely, apart from a number of people with possible COVID and with symptoms that might be COVID, we haven't seen the sort of increase that we might have been fearful of 2 months ago. And then lastly, a little bit just thinking about what the risk is of not treating our patients. If we don't treat our patients, their disease activity accrues, they become damaged. Depending on the disease, more serious things might happen to other organs. But this slide, and particularly if you look on the right-hand side, this is some of Paul Emery's work, and this is showing the association not just between age and the likelihood of serious infection with biological therapies, it's also showing the likelihood of infection with increasing disease activity. If we let patients flare, they will be more at risk of infection, and maybe that means more at risk of the serious consequences of the SARS-2 virus. And then the last thing to think about is how we plan for maybe not after COVID, but maybe living with COVID-19 over time, and the things we've probably learned and the things we might not change. Telemedicine, virtual clinics, these I think are now going to become much more standard, certainly in the practice within the UK that I'm within. I think that's not going to change. Maybe national bodies need to be helping us with education around how we should do this best. Drug choices will be informed by research, and my message for this would just be, I mean, if you look at something like hydroxychloroquine, I think on clinicaltrials.gov there were 104 different studies registered looking at COVID-19. We need less studies, and we need them of higher quality to really answer the questions, and we're waiting for those. One of the things I've really noticed is the lack of really good patient self-management resource online. That's something I'm going to see if we can improve locally, and maybe that's something for us all to think about. And we need to remain flexible for possible subsequent waves. So thanks very much for listening. This is clearly an unprecedented situation. It's changed how we work enormously. And those key messages of protecting our patients, assessing risk, that's really what we need to do, working out the nuances for individuals. Don't forget to treat the underlying disease. And then the last bit is, this has been traumatic for many patients, but traumatic for many members of staff as well. And we need to remember to look after ourselves and our colleagues. So thank you very much.
Well, thank you so much, Chris. That was beautifully clear and, as ever, very logically argued. So thank you, thought-provoking and utterly pragmatic. So let's move swiftly on now to welcome Professor Johannes Biljsma. So now the scenario is that the patient has COVID-19. So Hans, I'm going to have real pleasure in handing over to you to take us forward.
Thank you very much. So it is a pleasure for me to be here together with you to discuss some of the aspects of management of patients with COVID-19. Next slide, please. I have no conflicts to. So I'm looking at a lot of different recommendations that have been produced by many different national societies, have been produced by the ACR and the EULAR one, which is available next week. And if you look at them, and it depends a little bit at what moment in time they have been produced, if you really look at them, it's coming clear that at this moment, and of course we have to realize there's a developing period of time, there's no evidence that patients with RMD face more risk of contracting the disease than individuals without RMDs. So there have been a lot of observational studies, and there's no hard evidence to say so. Also, at this moment, there's no evidence that patients with RMD have a worse prognosis of COVID-19 when they contract it. So basically, this is good news for our patients. We have to be careful what's happening in the time, of course. Next slide. So therefore, most of the recommendations I just mentioned therefore suggest that patients with RMD should comply with all the preventive and control measures that are prescribed by the health authorities in their own countries. And as you know, it may differ a little bit from country to country, but basically they have the same items: isolation, social distancing, washing your hands, sneezing in your elbow, and so on. And our patients should comply with the same preventive and control measures as patients without RMDs. Next slide. So this is something already discussed by Chris. So we should be careful how to do this, and many of the patients are quite willing to postpone their meeting for 1 or 2 times, but nowadays they're becoming more eager to get in contact again. But we have our guidelines how to look at it. Next slide. So important is what to communicate with our patients. And we have to realize that most of our patients are worried and many of them are scared. And they have questions like, am I more prone to get the disease? Is my present medication, is it a risk or might it be a blessing? If I get the disease, is it going to be worse? Should I be tested also without having any symptoms? And of course, can I do anything additional to prevent getting the disease? Next one. So we have to reassure the patients where it's possible. but we have to stick to the facts. So we need to be easily accessible. But if there are no facts or not enough facts, we should mention our doubts, because we have to realize that everybody is overwhelmed with info, be it right, but quite often be it wrong. So what you tell them, another specialist may deny. And we've seen a lot of discussions that rheumatologists say you should continue your drugs and other doctors say you should stop it. So refer to trustworthy websites. And if you have a website of your own hospital, make sure there's relevant information for your own patients. Next slide. So what with a patient that has COVID, that has no symptoms, and he has been in a real contact with somebody who has tested positive for the virus? So real contact means being in the same room or something like that for a bit of a time, not just passing by on the pavement. But if somebody has been tested positive for the virus, the patient should be tested for SARS if possible. And we have to realize that in some countries, testing facilities are not easily available, and it takes quite some argumentation to get the test done. But I think our patients should be tested, and it could be one of the roles of the rheumatologist to ensure that this happens. Next slide. So what about the medication? So if a patient has not suspected or confirmed COVID-19, she or he should continue treatment, including the NSAIDs, including the conventional synthetic, the biological or the targeted synthetic DMARDS, and also including the glucocorticoids. So the advice to them is don't stop your medication. Next slide. If a patient then develops mild symptoms, then it's time to think about treatment changes, for instance, for the DMARDs, but they should be discussed individually. So there are some arguments to continue, there are some arguments to stop, and it very much depends on the individual person you have in front of you. So there's a balance between yes and a balance between no. You have to be careful, look at the individual patient, look at comorbidities and things like that. Next one. If it worsens, then the patient should immediately be seen by an expert in treating COVID-19, such as an infectious disease doctor, an intensivist. And we have to realize it's not the role of the rheumatologist to make the decisions there, but we should take a firm position as an advisor to the team that's helping our patient. And we are especially necessary in the area of medication to be continued, to be stopped, and so on. Next slide. So we have heard that there are two problems in the lungs. And as Kevin already explained, the pulmonary embolism was not seen in the beginning, at least not reported in the beginning, but we are now quite well aware of it. So everybody who's going to mechanical ventilation is anticoagulated. But what we know much more about is the cytokine storm. And here you see on the cartoon the names of many cytokines that we are very familiar with. And there comes into account whether or not our drugs are good or bad for our patients. Next slide. So there have been quite a lot of questions posed. So do patients with RMDs have an increased risk of complications with certain treatments? Should they continue their treatment? And what about using our drugs against COVID-19 in non-RMD patients? Next one. So, do our patients have increased risk of complication with certain treatments? There have been published a lot of studies, most of them open observational studies. And as far as they are reliable, and that's of course limited, but as far as they are reliable, there's no increased risk with the different treatments investigated. Neither with NSAIDs. There had been some report in the beginning, but it has not been confirmed and even spoken against it. Conventional synthetic, biological, or targeted synthetic DMARDs. Much more important are the comorbidities: obesity, cardiovascular disease, pulmonary diseases, diabetes, smoking. And we know that quite a number of our patients have been smoking in the past, and quite a number of our patients have pulmonary problems. So from some of the data that are emerging nowadays, give the impression that RMD patients, about 20% of them, have pulmonary problems. The discussion on glucocorticoids is still ongoing. There are clear pros and there are clear cons. There could be some bias by indication that those who end up with higher dosages of glucocorticoids tend to have the more severe disease. But I think basically the conclusion is, at this moment, we are not convinced that any of these drugs gives an increased risk. Next one. So should patients continue their treatment? As mentioned, the dangerous phase of the infection seems to be provoked by the cytokine storm, especially the pro-inflammatory cytokines that we know so well from our diseases. Therefore, it doesn't seem very logical to stop medication that could temper this cytokine storm. And in addition, as already mentioned also by Chris Edwards, experiencing a flare of the disease when also suffering from COVID-19 is not wanted either. So at this moment, the advice would be when contracted COVID-19 patients should continue their RA treatment. Next one. What about using anti-rheumatic drugs against COVID? So in patients with RMDs who are using them, we just discussed to continue them. However, in non-RMD patients not using them, should they start these? We have heard about a few of the studies that have been published. Basically, we could say that no randomized controlled trial has shown the efficacy of any of these drugs published yet. So I think the IL-1 is too small to make a firm conclusion. The antimalarials have been, I think, quite well evaluated by now, and still studies are going on, but they're not promising. IL-6 inhibitors, I'm aware that over 20 different IL-6 studies are on its way. And we heard a preliminary press release from a study in Paris, but that has not been followed up. It's looked promising, but there has not been a follow-up. We have not seen the data, TNF-alpha inhibitors and others. So I believe that until unequivocal evidence for patients who have not are not RMD patients, no indication is there outside research. We really need the data, but we only can get the data with adequate research. Next one. So clearly needing more data is something that some people started straight away on. So there were a very enthusiastic group of people who already in February started what they call the Global Rheumatology Community's Response to the Worldwide COVID-19 Pandemic, the Global Rheumatology Alliance, supported by the ACR, supported by EULAR, supported by many national societies, pharmaceutical companies, and so on. And they did an enormous amount of work. Part of it is, next slide, the EULAR database. Next slide. Which is separately, but also completely part of it. And there are some reasons why we need some separate getting of data in Europe versus other places in the world. And that will be discussed by Kimme later on. But we are in a too early stage at this moment to make final decisions. So I told you a little bit about what is the state of the art that is based on published science and which is used for many of the recommendations. And clearly it's a developing area. And I'm quite sure that 1 month later or 2 months later, we might say some different things in this area. Thank you very much for your attention.
Thank you, Hans. And yet another really crystal clear presentation with very practical and pragmatic advices. My grateful thanks. So let's move to our final formal presentation. Pleasure to welcome Professor Kimme Hyrich from University of Manchester, who is one of the foremost epidemiologists in the world of rheumatology and is going to take us through the state of current COVID-19 registries. Kimme, over to you.
Right. So thank you very much, Ian, and thank you everyone for joining. And I'm really pleased this is such an international audience because the database I'm going to tell you about is open for every single one of us on this webinar to enter data on our patients. Next slide, please. Next slide. So as Hans alluded to, the COVID-19 Global Rheumatology Alliance, or the GRA, is probably the fastest established database in rheumatology, perhaps ever. Within 3 weeks from inception, it was ready to capture data on patients. It actually stemmed from an idea in inflammatory bowel disease, where there had been reports that patients with IBD were not acquiring COVID, and it's almost the thought that can't be true. So the IBD community set this up, and then a single tweet from Leonard Calabrese suggested maybe we should do this in rheumatology. So here we are. So we all are working under this global umbrella of the Global Rheumatology Alliance, and the real mission here is to collect, analyze, and rapidly disseminate information about COVID-19 in patients with rheumatology conditions. This is a very different feel of a database to what you might be used to hearing about in rheumatology. We're very well set up in rheumatology with big national biologics registries such as the BSRBR or RABBIT. We have big claims databases. Unfortunately, none of these are really agile enough to respond, as we've already found out, at least for those of us that run some of these, when we're faced with trying to get information out so fast. Next slide. So the COVID-19 database was originally envisioned as a single data entry point. There would be one database that everyone in the world could log into and put their patients in. However, within Europe in particular, there's concerns about data protection, and we have some very specific and quite strict rules about data protection in Europe and transfer of data outside of Europe. So therefore, with a database based in the USA, this was going to cause some very quick issues. And therefore, almost within a 48-hour period, we very quickly decided within EULAR to launch a parallel data entry point within Europe. And the data is being held at the University of Manchester. And before anyone else asks, Brexit aside, we are still under EU regulations. Next slide. So just to show you the interrelationship and to reassure everybody that we are still working within a single big, larger database, we have the Global Rheumatology Alliance, which has 2 data entry points, the global database and the EULAR database. One of the advantages of having a EULAR database was that within EULAR, many of our countries are fantastically set up to capture these data themselves, either within electronic medical records or within databases similar to this that were already set up. And I think one thing that's been a real success so far of the EULAR database is the intense international collaboration that's been going on. And we've been able to set up agreements with a number of national databases, including Italy, Portugal, Sweden, Germany, where data are captured locally and then transported into the EULAR database at fairly regular intervals. It joins the data that's coming in from direct entry, and then all of this can flow into the Global Rheumatology Alliance. All of these databases are set up that actually prevents people from putting data into the wrong database. So one of the challenges is to make sure we're not capturing duplicates. Just a little bit about the ethics, legal, and oversight. So one of the first things we had to do was understand what are the ethical implications. Do we need ethical approval? Do we need patient consent? And the database was reviewed both in the USA, it's been reviewed in UK, as well as a few other European countries. And where it's been reviewed, it's largely been deemed to be non-research, meaning this is not something that requires ethical approval by your healthcare authority, and we don't need patient consent. And largely this falls into the fact that it's a non-interventional database and there's no patient identifiable data. For those of us living in Europe, under GDPR, this is GDPR compliant. The only identifiable data captured belongs to you, the reporter. The rest of the data is completely de-identified, and particularly when we transfer data outside of the European Union, we ensure that even the reporter data is removed. So it's a completely anonymous database. The oversight of the EULAR, branch of the GRA is falling under the EULAR Standing Committee for Epidemiology and Health Services Research. Pedro Machado from London chairs that, and on our steering committee is a fantastic group of epidemiologists as well as patients. And Pedro also sits on what is a single GRA Global Steering Committee as well, so it's well represented. So just a few points on practicalities for those of you that are wondering, how do I report a case? You can access this through the dedicated EULAR COVID-19 database homepage. This is here, and it's very clear. As soon as you click onto this, there's a place where you can click here to enter your data. If you're in one of the other national databases, the links are here. And if you click through and you're outside of one of the EULAR countries, the link to go into the global database, which is capturing data from the US, and in fact, every other country outside of Europe is there. This is the most simple online form that you will find. It's almost 100% tick boxes. It's capturing data on the diagnoses, the rheumatology treatment, the COVID-19 treatment, the complications we've been hearing about, as well as the outcome. And a lot of this is at somewhat of a grainy level, and other bits are actually quite simple, because at the end of the day, we want to know what was the main outcome for our patients and how did they get there. Who can you report? Well, it's any case with COVID-19, and we would want you to report asymptomatic cases, mild cases, not just the most severe cases, and to include cases that you think had COVID-19, but you were unable to confirm that with a test, because in many places, including where I live in the UK, until recently, community testing was often almost unheard of. The other thing to point out is this is a database for children and adults, and it's largely focused around people with pre-existing rheumatic disease, but we do have a focus on inflammatory diseases. So with a few exceptions, these are mostly for patients that have diseases that may require immune suppression. This is not the database where we're looking to report outcome in patients that may say solely have fibromyalgia or solely have osteoarthritis. And the last thing to say is it's important that you don't report the minute you hear about a patient who has COVID. Because the data is anonymized, the way it's been set up, we can't go back and update it. So we do ask you to wait possibly up to 14 days. For some cases, this may be longer, to not report the patient until you know the outcome. So I want to now just briefly talk about the analyses of the data in here and the reporting. So the database really is viewed as a rapid response to a public health emergency. And the aim is to disseminate information rapidly. So a lot of the information coming out is not going to be data that requires hours and hours of a statistician's time. They're going to be quick snapshots of who is it that's getting COVID, what are the main outcomes for our patients. As the database grows, I'll come up in a second to the numbers, this will give us more and more opportunity to start to do more statistical approaches in a way almost set up either as descriptive analysis or as a case control study where we can compare outcomes and treatments between patients who do and do not have certain aspects. It is not a database set up for research as we know it. So what can these data tell us and what can't they tell us? So this database, as I mentioned, is going to allow us to rapidly document the types of patients, such as their diagnoses, their DMARDs, who are acquiring infection. And with this, we will be able to, as the database grows, start to identify patterns of patient characteristics. So we can look, are the same risk factors for severe outcome in the general population the same ones that we're seeing in patients with rheumatic diseases? What is the proportion of patients who are hospitalized and are on certain biologic therapies? What it can't tell us, because it's not a prospective study, is it's going to be facing a lot of bias. Because of the lack of community testing, we're likely missing asymptomatic or mild cases. As a rheumatologist, we may never know, at least for some time, if our patients are even thinking they have COVID infections. They may not contact us. There's a high likelihood of bias because the ones, at least in my own personal situation, that I'm hearing about are the patients that are being admitted to hospital. And because we have no known denominator of the population at risk, this isn't the way that we will be able to address what is the incidence of disease severe disease, or come to any definite conclusions about any cause and effect between outcomes and treatments. So as I said, we aim to rapidly update data, and on the database website on the EULAR, there's a similar one on the global database. Once a week, we update with a report. And just to give you a flavor, this is data that was in the European database up until tomorrow. So overall, as until the beginning of yesterday, there was over 1,500 cases within the global database. There was 771 within the global database. I must say the overwhelming majority of these patients are American patients. And then the EULAR European Registry has 776 patients, and currently we have patients from 26 countries. The feeling is that there is a very strong bias, as I've mentioned. 61% of our cases are cases that were identified through hospitalization, and 15% of the patients have died. And although we do have patients from 26 countries, there is a significant proportion that are from these top 5 countries currently. They look like a rheumatology population. They're 63% female. I mentioned this is open to children, although we have very few children currently, and the majority of the patients are over 61. The age range is actually from 8 up to about 98 years. Spondyloarthritis and rheumatoid arthritis are the top diagnoses, but I can say as we go down the list, we have patients with almost every rheumatic disease. So there's patients with systemic sclerosis, there's patients with Behçet's disease, patients with vasculitis. Across the board, patients are coming into our database. There is no particular disease for which we have not seen a case of COVID. Our patients do have a lot of comorbidities, probably a higher rate of comorbidities in this population than one might see in a normal rheumatology population. Only 26% state they have no comorbidity. And the DMARDs at the time of the COVID infection, about 80% are on any DMARD. 60% are on conventional synthetics, with fewer patients on biologics and targeted therapies. And I've included the specific numbers here rather than just the percent to show you that even though we are now at a case where we have close to 1,500 patients, we're still going to be somewhat limited to describe some of these. So we need to continue to acquire patients. So with only 19 patients on JAK inhibitors currently, it's going to be very difficult to draw any conclusions. So I think that's my last slide. Apologies for my very quick Canadian voice, and I'm happy to hand over to you, Ian.
Well, thanks very much indeed, Kimme. That was terrific. Your Canadian voice was quick but utterly succinct and gave us a whole lot of beautiful information. Now, if this magic technology works, we're about to have a gallery of all of our panelists. How marvelous is that? Absolutely terrific. Well, it's one of those moments where you're delighted that everyone is still awake and that no one has put their feet up and snoozed, or Kevin's got his running gear on and just nipped round the corner. Maybe he did and he's come back and looking remarkably fresh. So I have to tell you folks that we've got 193 questions, and we have unfortunately only about 20 minutes to answer them. So what I'm going to do is try and get a flavor of some of the questions that have come from our delegates, both those that were pre-submitted and also those that were submitted live. And I know already that we're going to disappoint a few colleagues because the live questions and the submitted questions were quite terrific. I'm going to start possibly with one that I'm going to maybe ask you, Chris, to take this one first up, but others can feel free to reflect. And it's a question that is representative of quite a few. And, you know, for example, the BSR have currently published guidance for risk stratification, advocating shielding and social distancing. And Chris, you showed that table that BSR put together. The ACR, EULAR, BSR guidance suggests stopping biologics when someone gets infected. And the question is, are we being overly cautious? So Chris, I'm going to hand that one to you first, but maybe Hans, you might want to come in as well, just based on our response. Are we being overly cautious in stopping our biologics when a patient becomes positive for COVID-19?
Hopefully we'll have some different views and there'll be a bit of debate. I mean, my normal practice would be in the in the setting of a potentially dangerous or life-threatening infection, I just stop those things when people are admitted to hospital. If someone needs IV antibiotics or admission, because it clears the decks. In reality, with the half-life of some of the drugs, they're not going to be out of the system until the patient's better or worse, but it just decomplicates the whole situation. Now, that may be overly cautious, but I think probably a week or two off and then restarting it once someone's recovering is probably not a big price to pay for that. That would be my approach.
No, thank you. Hans, do you want to add to that?
So if a patient indeed has symptoms of COVID, then there's an individual decision, also based on comorbidities and things like that. It's not standard that we should do so. So we are, in some of the recommendations, people are saying, well, many of those drugs may be beneficial in effect for the cytokine storm. So why stop them? And also realizing that some of the drugs take more than a few hours to get out of the system. So then you have the idea that you're doing something, but actually you're not doing something. So individual based, I still think, not standard stopping. And that's why I say it's so important to involve the rheumatologists at that stage in the decision making.
Yeah, I mean, the key thing is going to be looking over time at what happens to people on different biologics, or no biologics for that matter, and see how well they do. Kimme, do you want to comment on that? Because that's, you were pointing out strengths and weaknesses in the registries that have been created, but maybe any thoughts as to how we might get at that question?
Yeah, there's strengths and weaknesses of the data we have, and there's also strengths and weaknesses of our public health system. And one of the challenges, I'm not sure about my other colleagues on the line, but I work at one of the largest NHS trusts in the country, and I think we've had 4 patients with severe COVID come through the doors. And because many of these patients are shielding away, none of our patients are being exposed, and therefore it's really going to limit what data we have. So I think what we may have to do for some of these is turn to very large databases. In the UK, there was a recent publication of 20 million people, did include almost 1 million people with maybe poorly defined rheumatic diseases, no access to biologics. It did suggest that these patients may have a slightly higher rate of death, but I think until we can really get down in with our biologics registers where we have all of these data, assuming we've got the power to actually look at this outcome, it's difficult to advise right now anything different than what's been said.
Oh, thanks, Kimme. Just developing, and again, this is a synthesis of several other questions. Are there any particular modes of action of drugs that we prescribe that give anxiety? And I'm going to call out rituximab here, not through anything vindictive on my part, but simply because it's a question that quite a lot of our delegates have asked. And I suppose it's one that is quite often used in some of our sicker patients. I don't know, Kevin, if you want to kick off there, but I'll open that out to the panel momentarily.
Yeah, sure. I get asked the same question. Kind of tying into the last answer, I mean, we're going to gain some of these answers too with real world data, like Kimme mentioned, but also through RCTs. A number of these drugs, of course, are being used at various stages in illness, primarily to prevent the cytokine storm that Professor Biljsma went through. And, I think, I worry about the JAK inhibitors probably more than any of the drugs in terms of their ability to downregulate innate viral responses. But again, baricitinib may be different. The other issue is maybe you combine some of these drugs with antivirals approaches, and that you're seeing that now in some of the trials. It may also be one of these things where there's really different risk periods. I talk about, there's a risk of being infected. So some of these drugs might increase your risk of acquiring infection. Some of these drugs then may modulate your risk of progressing once infected. And some of these drugs may modulate your risk, kind of the later stages. There's really, if you've really progressed and you're really sick, it may change your risk of dying. So there's kind of 3 time points, and it may depend on when you're using that drug or when that exposure is in terms of how it changes your outcomes. It's I think very complicated. I think, rituximab is one of those drugs that might interfere with the building of long-term immunity, of course, to the maybe it's more of a risk on the back end. I mean, we just did, it's not published yet, it's being submitted this week. We just did a case finding exercise in the US among ID docs looking for these types of patients. And, you know, we found, you know, like everyone's saying, a paucity of patients really. And I think Kimme's right. These people are hiding away and they're sitting in their houses and not really going out. So I think there's less exposure out there among this group than there is a general population. But we did find a number of people who died who were on rituximab. You know, we're talking small numbers here. We had like 35 people on biologics, and, you know, 30 of them were on TNF blockers, and they all seemed to do fine. And, you know, 2 out of the 5 rituximab treated people died. So whatever that's worth, it's anecdotal or it's a surveillance exercise, really small numbers. But I think it may be, there's a lot going on there to control for when you do those studies. Underlying disease, of course, is really important, and those tend to vary between people on rituximab and other drugs. So I think it's going to be an answer that comes later as we look at real world data.
Thanks, Kevin. Just a variation of the same question. We talked about stopping immune modifiers in people who develop COVID. What about stopping them if a family member develops PCR proven COVID? What is our advice to our patient when it's a family member with whom they co-reside? That's one of our great questions from delegates. Any thoughts there? Chris, you're looking least scared of the panelists in front of me.
That's probably because I'm in a daze. Who knows? Who knows? What do I think? I think if someone developed it, I would give the general advice of trying to isolate themselves within the home, hand washing, all the standard advice that all health authorities would give at the moment. Just try as well as they can. But I don't think I would stop the drug in that situation. I would wait until they develop symptoms themselves or tested positive.
Yeah, I think there's that would be my own approach at the moment as well. So I want to just quickly deal with hydroxychloroquine before we leave this little section on our rheumatic drugs. And actually this comes from the famous Dr. Kush, so you know what's coming. It's an off-field question, but it's a great question.
Tweet it in a minute.
If you developed COVID yourself, to the panelists, would you immediately swallow large amounts of hydroxychloroquine?
No.
You can answer, or you can simply shake your head or nod your head. I'm seeing shakes.
I don't need it.
The thing I just call out with this, I mean, I wouldn't. I hear lots of anecdotal, scary stuff from situations where people have been given high-dose chloroquine and hydroxychloroquine in ITU settings, and they get QT problems and cardiac toxicity. Kevin mentioned that already. And it's just a real call out for, there are more than 150 hydroxychloroquine COVID studies underway at the moment. That's going to cause a lot of confusion. We need more collaboration. We need less studies of higher quality, because we really want good answers to this.
And another item is there, of course, that this drug is needed by quite a lot of our patients, and that it becomes unavailable for many of them because of this kind of use, which is not based on any science.
I just add that if I got it, I think I'd go on about 10 or 12 things. You can tell Jack.
So I have to say that there is an article in the Annals, either just out or about to be out, which demonstrates definitive evidence of shortage of hydroxychloroquine for people with RMDs. That study came out of Canada, but EULAR has looked extensively across European countries, and we find relatively widespread shortages of the drug now. So I think there is due pause for thought here on making sure we have medicines available for the people who definitively have an evidence-based need for it.
Absolutely.
But anyway, that was a moment of gentle levity. Let me now turn to a couple of really interesting questions. Smokers, are smokers protected? I'm going to throw that out to you, Kimme. Do you think we're going to be able to ever answer that question very well?
Well, geez, I'm not going to be the first epidemiologist to tell you smoking's a good thing, so I'm going to defer to say that.
I was hoping to get that quote, note it down, and use it for years.
Look,
you're too clever.
Yeah, look, smoking is going to be bad all around. It's, predisposes people to the lung diseases that are the comorbidities putting people at risk, higher rates of pulmonary infections. This is not advice, and I would be highly skeptical of the study design and what biases were involved if that was the finding.
Sure. That's very clear. I think let's now think a little bit about something we can do that's very practical. And Kevin, we're a little short of time, so it's a quick question and I'm expecting a quick answer. Should we be optimizing vaccination status across the range of infectious diseases during this COVID crisis? And bearing in mind, we're about to enter a kind of peri-COVID endemic phase of our clinical practice. So I guess the question is, what about vaccination across the range of of infectious diseases?
Sure. The quick answer is that COVID is hindering vaccination, both in kids and adults currently, because no one's seeking care in general. So I do think we have to pay attention to it and make sure everyone's up to speed as much as possible on vaccination. In terms of vaccine preventable diseases, we haven't seen a lot of bacterial superinfection of patients with COVID. But again, the lung disease associated with COVID and the comorbidities associated with badness in COVID certainly speak to the importance of vaccinating across the spectrum, like you mentioned. The last thing I'll say is there was, you probably saw the results yesterday, very preliminary phase 2 results of a new vaccine. It was just in eight individuals. I guess you'd call it a phase 2A, but the 8 individuals were able to mount neutralizing antibody responses after the vaccine was given. So that was encouraging to see. And I think probably, in 8 to 12 months, we should have a vaccine for this entity.
Yeah, well, let's absolutely hope so, because it would enormously simplify life in every respect and take away something which I was going to come back to you, Hans. You said something that had real resonance with me. We've recognized this in our patients as well. Patients are scared. People are scared of coronavirus, and when they have it, they're scared because they have coronavirus. I thought that was a remarkable point to bring out. I don't know if you want to develop the point any more than that, or simply leave it as something that is really important in management of these people.
I think we have to realize this when we are talking with patients. Quite often they hide their anxiety behind questions, but behind the questions quite often there's the fear. And then if you talk about them and try to reassure what we know, what we can reassure, that really helps. And then some of the questions disappear completely. So I think we should be very much aware of that and in every contact with our patients.
No, that's very clear. I thought that it was a particularly sensitive point that you raised. Now, I'm going to turn now to several questions that I'm going to compress them into 2 or 3 key questions, but there's about 50 or 60 that reflect what I'm going to say. And that is, some of us as rheumatologists are now getting phone calls from ICU and critical care doctors asking, how do I spell tocilizumab? How do I pronounce upadacitinib or some of these medicines? But of course, the message is really, can you give me some advice about their use? So what is your take home at the moment in terms of actual evidence for the use of immune modifying drugs in the severe end spectrum? So let's imagine pre-ICU, but someone's got those risk factors, Kevin, that you mentioned, the D-dimers, the IL-6, if someone can measure it, the CRP is a surrogate going up, ferritin's going up, lymphocytes going down. Maybe, and I'm going to start with you, Kevin, you had a couple of slides in there. What about immune modifiers in critical care and ICU COVID at the moment? What's your take home?
Sure. Quick take home is there is some data. I mean, there's publicly available data as per a press release, at least from Regeneron, about a week or 2 ago from their phase 2 study with sarilumab. And there was reported benefit in certain subgroups of patients. And those were the critically ill individuals. So that's now in phase 3. So we'll see where that goes. you know, Sanofi has a trial, and then of course Roche and Genentech have their trials with tocilizumab. The data I've seen from those have been more open label experiences and not double-blind RCTs. So the open label suggests there might be some benefit, but you know, as usual, caution the interpretation of open label data. Lots of times in RCTs, those things don't pan out, and we've seen that here with a number of the therapeutics being tested. So I think it's really early with IL-6 blockers, Ian, and you know, really what we look forward to the phase 3 data. It should be soon.
Yeah, maybe as an editorial remark, one of the things I'm actually a little uncomfortable about is how quickly the global community has decided that this is a cytokine storm. And that within 2 or 3 weeks of the discovery of a brand new disease, you know, as rheumatologists, who you'll not be surprised to know, believe to be the very best immune investigating clinicians in the world, as a community, we understand these medicines. And yet, you know, after 20 years of using targeted immune therapeutics, we're still struggling to know when to use them optimally, in which patients we're going to get the best response. And yet somehow it's become creed that the cytokine release syndrome starts at day such and such in a subset of patients. And I have to say,
I'll just add back that, I mean, that's my problem with that remdesivir data that's been very preliminary released. I mean, I can tell you it's very complicated to understand, like you just said, timing issue. You know, how far out are these people from the time of infection? Where are they in this quote unquote cytokine storm that they may or may not be having? And, you know, I think IL-6 levels, there's a number of biomarkers that probably will segregate certain types of patients in terms of who's going to respond and who's not to certain types of therapies. So.
And the real interesting thing being that if we're treating in trials that put different types of people at different stages in the illness together with different comorbidities, we could end up with negative trials that miss actually highly effective therapies in subsets. And as an experimental medicine specialist, that really concerns me. Kimme, you're nodding. You almost never agree with me. Is this that moment when we've both come to the same conclusion?
Yeah, I mean, it's such a rapid moving area, Ian, and you know, study design and good practice seem to be falling the wayside on many of the clinical trials that we're seeing registered. You know, I think we don't know about these, and I would always encourage people that where possible, the treatment should be within studies, ideally with biological data captured.
Yeah. And I would argue strongly, and this has not happened in the UK until very, very recently, that we should be trying to stratify the entry into those trials, because that's going to give us the best chance of seeing effects.
So not only patients are guided by emotion, but also the clinicians, the trialists, and so on. And ethical committees are not needed anymore, and a lot of things are happening that are disturbing, I would say.
I would absolutely concur. I'm going to pick up a couple of really quick questions. One to you, Kimme. For the registry, can we report patients with gout?
Yes.
Thank you. Well, that's a great question from someone. And now there'll be many cases of gout being reported into the registry, at least 1,500 from all of the people on this webinar, which is very gratifying indeed. I guess that just about brings this discussion to a conclusion. I think we've had a truly extraordinary conversation. I want to say a few words just in bringing together what I've learned, which is an enormous amount. I've learned first and foremost that the virus is new, but that by going back to the original SARS to MERS, looking at comparative viral biology and thinking of the lessons that Kevin has given us, there is really quite a bit of comparative biology that we can now bring through into our current experience. And the idea that we may have a protective vaccine, it's so enticing. But of course, we have to simply wait and see, and we have to be very patient. But it is really encouraging to see so much investment at the moment in vaccine biology. And in some respects, as I guess an immunologist as well as a rheumatologist, it's great to see that degree of enthusiasm in the political classes perhaps a little late in understanding pandemic management and the importance of being prepared for new emerging agents. And then we've learned from Chris the importance of setting individualized targets for each patient. We simply can't put large groups of folk with a diagnosis into one room and tell them all to do the same thing. And so we must be thinking about the comorbidities that people bring into the conversation. People who are, I think obesity is a particular concern. That's really come through loud and clear in most of the clinical studies reported so far, more so even than asthma or COPD, or that one might have thought at the beginning would have been the things that really stepped up. And of course, remember that many of the RMDs are associated with accelerated cardiovascular risk, with hypertension, with being overweight, because it's difficult. If you're sore, you can't exercise as well. And so we have shared morbidities in the RMDs with COVID poor outcomes. And so we have to be incredibly vigilant. And from Hans, we learned further that we should think very carefully, cautiously stopping as required, but because of the half-life of most of our drugs, that becomes an irrelevance. Communicating with other clinicians, the rheumatologist is a key player at the center of that therapeutic journey for the patient, and that continuing conversation. And the fact, I think, Hans, that you made that was especially salient for me was remembering that our patients are scared. And Kimme, thank you for telling us about the power of epidemiology in times of uncertainty, gathering information, and what an extraordinary community effort. Rheumatologists around the world coming to the fore. I think that speaks volumes of our discipline. I've oft said in public that rheumatologists are the best of all the physicians. We have to be pleiotropic in our knowledge base. We have to continually understand new dimensions in our diseases, but we are still fundamentally patient-centric, with the patient at the core. So please feel free to give us a little feedback. I'm going to have to draw the seminar to a close momentarily. The website is there. We're going to be updating on the cytokine signaling forum a whole lot of information that will allow you to go back, refresh your memory. I'm sorry that we were unable to answer every question. We would be here for another 3 or 4 hours on that basis, but we're going to try and pull a synthesis of those questions together and make sure that the evidence, such as it is available for you on the website. Remember that you can get a certificate of attendance for your CME. Can I say thank you, first of all, to AbbVie and to Lilly for facilitating this interaction. As you can see, it wasn't really remotely drug-centric. It was about people at risk of or with COVID. And my final words of thanks are to my fellow faculty. Thank you so much for sharing your knowledge. And when there's very little evidence around, it's actually quite risky to be a member of such a faculty, because you're inevitably being asked to expose judgment as well as knowledge of the literature. You did this in an exemplary manner. I learned much from you, and I know all of our delegates did. And lastly, to all of you, thank you so much for joining us in such large numbers. I hope you found this webinar to be of value in your clinical practice, and very especially at this time. Thank you for being part of the amazing community that is rheumatology. I wish you the very best in your practice, knowing that you're probably doing things in clinic that you don't normally have to do, taking on questions that you don't normally field, and making decisions that are especially difficult in times of limited evidence. I wish you all the very best in that, and I hope that you do stay healthy.